Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. This material is based on content provided by BeiGene. It has been reviewed by EHA, which found it unbiased and aligned with EHA educational standards, as well as reworked by EHA to create an effective educational experience.
We're going to be having a chat about some of the issues that actually affect our patients facing CLL. I'm Lesley Fallowfield. I'm a professor of psycho-oncology at Brighton and Sussex Medical School, and...
Yes, you might know me, Clemens Wendtner. I'm a hematologist from Munich. I'm happy to talk today with Lesley about this subject I'm usually not trained in, but I think seeing patients, I think we can exchange some experiences.
Okay, so I guess what I'd like to start by asking you, Clemens, is some of the advances that have been made in treatment terms. So this changing landscape, I mean, what difference has that made to you when you're seeing patients compared to when you were a baby doctor?
Yes, right. So starting in the CLL field in the, I would say, late 90s, I think we were happy that we had a drug like fludarabine available. So the PERN analogs came into the field, and we are not even talking about chemotherapy at all. And so it's still questionable whether bendamustine, a drug, for example, Kirsten Fisher and myself liked very much 15 years ago, it's questionable whether this drug is not inducing any damage at all. We have heard yesterday from a young guy from Barcelona that even we can induce more than 100 mutations using bendamustine. And from the patient side, I think it's important now when patients think we will treat their leukemia, they might have pictures in mind, that this means staying on the ward, losing hairs, and having a lot of emesis and nausea. I think this is the first misunderstanding we have really to cope with.
Great. So, I think it's fair to say that the sorts of things that might excite a clinical scientist can be less exciting to a patient initially experiencing this very frightening sort of diagnosis, especially because, as we know, some of these patients might be fairly asymptomatic and it could even be diagnosed via a random blood test. So I wonder if I could talk to you a little bit about nomenclature, the words that we use, but one can only make a choice about things if you understand what those choices are. So, it's pretty difficult, isn't it, for an anxious patient who's suddenly being told they've got a potentially life-threatening disease to cope with these esoteric concepts and words. I can't pronounce things, let alone the names of the drugs. How do you cope with that?
Yeah, it's getting very difficult even to remember all the names to pronounce them correctly, especially think about the patient having never had any contact with these kind of drugs. So we have to take some extra time. We have to write things on a sheet. I usually also use my laptop and show the names so they have the chance to read the names at least. But I think even before talking about a specific therapy, we tell patients they have a leukemia and it's an early stage and we send them home. So the patient is leaving a door knowing he has a leukemia, and this is also, a kind of anxiety-inducing situation for the patient, having a sword of Damocles swinging above her or him. And this has to be reflected also by the physician, that we are happy telling them it's early stage. For us, it's good news, but can still be bad news for the other side, the patient.
I think that's a really interesting issue, isn't it? Because if we think about all the public awareness campaigns that have gone on, I think the message for most of Western Europe at least has got through that if you find a symptom, go and report it early, and if you get early diagnosis, treatment will be initiated and you've got a prospect of cure. So this goes counter to everything people have heard. Hey, you've got leukemia, but guess what? We don't need to treat it yet.
Right.
I mean, it seems counterintuitive. And I wonder if there's ever a situation where a patient is so panicked by the fact that they have got this life-threatening disease that some people might be tempted to treat a bit too early.
Right. I mean, there's this kind of temptation, as you said, the action mode, I call it, just doing something, although we know, based also on big trials, CL12 trial by Peter Langerbeins, for example, showing definitely there is no use even in high-risk early CLL to treat. But it's also for a physician sometimes could be unsatisfactory to send out a patient without doing anything. This has to be learned, and so we have to take these kind of mental health issues very seriously. It should be said that in CLL, there is not only a medical need for this kind of mental health issues. I think there's also a scientific gap. We know it from breast cancer, from prostate cancer. A recent trial in bladder cancer, for example, shows exactly we have in 31% of patients mental health issues, depression, anxiety, fear to lose any, also welfare issues, things like this. But there is no good science in CLL so far, and this can impact also on the treatment outcome. There are data from other trials that it's not only the mutational status, it's not only TP53. These simple issues like depressive patients not taking a pill, we are using mostly pills, venetoclax, BTK inhibitors, can negatively impact also on the outcome. So I think that's very important to stress.
Maybe we can come back and talk about how well we do measure mental health issues in our patients in a bit. But I want to come back to this sort of like seemingly difficult concept for a patient to embrace that, yes, you've got life-threatening disease, but the good news is we don't have to treat it. So what does that patient actually do? I'm sure all of you know the phrase of, sort of it's not watch and wait, it's watch and worry. But I think we actually don't look at the personality characteristics of patients sufficiently to recognize how we have to potentially change the wording a bit. Because for some patients, when you tell them those sorts of things, they'll probably actually go away feeling perfectly happy about it. They're able to almost sort of ignore it. But I wonder how many fall into that category rather than becoming vigilant about every ache, pain, sore throat, lump or whatever. And worst of all, those patients who have an anxious predisposition anyway, a trait of being rather anxious, how many of those become hypervigilant, constantly going to their primary care physician, reporting things? So, I mean, how do we deal with that, first of all?
I think there is a significant fraction, just palpating lumps and bumps all the time, and we all know these Excel sheets. Patients are presenting to us with leukocyte counts, and we are a little bit annoyed sometimes, but this seems to be this is done by some patients that want to gain, by doing this, again, some self-control, because they're losing control when we tell them something about a still early stage leukemia, but this is out of control. And I accept this for my patients because I know maybe this helps them to regain self-control, although I'm, as a physician, maybe sometimes a little bit annoyed, because it's useless whether you have 23,000 or 25,000 leukocytes 2 weeks later.
So what about now sort of coming on to, let's assume that the patient is going to receive some treatment, but that could be continuous or intermittent. Again, you've got a bit of a problem here, depending on, I would suggest, not just the characteristics of the disease, but the characteristics of the patient and how they can accept that.
Yeah. I mean, we usually say time-lapse therapy is an extra bonus point for the therapy. I mean, we all know that we have to base a treatment decision on, usually molecular features, IgG status, TP53 status, things like this. In the end, we make a choice, but there are patients that are very happy with time-lapse therapy, knowing this will come to an end after 12, 15 months, something like this. But also patients being on Ven/Obi, for example, there are some patients being horrified when, the treatment comes to an end, whether they are safe enough when we stop. Then sometimes very peculiar things start, that patients are asking for MRD assessment. We, again, just heard this is usually not routine practice, but still they want to know exactly about their disease status. MRD assessment is asked for. And so this, we try to convince them this is maybe not a routine practice and this is maybe useless. Within clinical trials we do it, but outside of clinical trials it's not done. On the other hand, we know there are treatments, continuous treatments, as you just mentioned. This is when I tell the patients you do take this pill lifelong. Lifelong always sounds frightening. I usually then say, okay, an antihypertensive drug you're also taking lifelong, but you would not think about stopping a hypertensive pill. So I try to make this kind of pictures or similarities in medicine so that patients accept this kind of treatment. Also continuous treatment can be the safety pill, let's put it this way, every day, they are taking. This can also be a gain, or the patient can gain reassurance by taking a pill every day.
Now, that's an interesting sort of point, really, isn't it? Because obviously anxiety that this disease might sort of kill me anytime soon is a psycho-noxious experience for anyone. But there are better ways to treat anxiety than to put people on expensive drugs with potential side effects, aren't there? And I just wonder how many people have within their centres good, well-integrated psychological support services that patients ought to automatically be referred to, I would suggest.
I think there is still a major lack, also in Germany, that we routinely don't refer patients to psychology specialists. There are some patient advocate groups, and support groups. We just give addresses and we just send them there, but we have, for psychology support, we have long waiting lists also. I think this is still an unmet medical need, that we have to take these kind of disorders being induced by the leukemia diagnosis, that this has to be covered also in a way by good psychology support in the system.
I mean, it's quite interesting, really, isn't it, that I think some patients feel, but I'm not mad. And I that's why I think it should be integrated, that this is an important part of care, because we are always dealing with uncertainty in this issue. And I think the general public actually do believe medicine to be much more of an exact science than it actually is. As we all know, facts are only sort of hypotheses that are either refined or supported by the latest research data. And trying to cope and deal with that, I think, is pretty difficult. And I'm going to tease you with another sort of thing about uncertainty, and that is there are quite a lot of data now coming in different areas showing that the tolerance of uncertainty of the clinician who is talking to the patient will also affect what the treatment decision is. Because if you, as a doctor, are highly intolerant of uncertainty, you're more likely to, early on, I think, provide more aggressive therapy, order up more tests.
That's correct. I think we learned an expression during the COVID pandemic. This is resilience, right? And I think that this is also important on the physician side, to gain resilience, and this can be trained, and to just keep cool and bring the message to the patient, but not just getting nervous about the leukemia per se and starting irrational treatments too early or things like this. So,
do you ever feel blamed by the patient if in fact you've reassured them and then the disease does?
Yeah, I mean, also you have to be also resilient on this, because as a physician, you might get blamed to be inactive and doing nothing, but it's a matter of convincing. I usually try to convince them, there is no need, because we know exactly you will not benefit when we start too early. We might even harm you. But this depends then also on the patient side, whether the patient is accepting this kind of scientific knowledge from the physician.
So communication is really very important, isn't it? And I guess there's also a social, legal, moral imperative now to be more patient-centered, to involve patients more in their decision-making. But I guess I come back to where I started here, that it is phenomenally difficult to explain the rationale and logic for the sorts of treatment management policies that you feel, from the data that we have, are most appropriate. So trust in the doctor becomes vital. If a patient doesn't really understand things because the concepts are too difficult or challenging, trust in the doctor is important. And we know again that if the patient doesn't understand, if the patient actually doesn't trust the healthcare professional's advice, they're very easy prey for the purveyors of snake venom on Dr. Google. Dr. Google will come up with all sorts of brilliant ways to treat CLL. Does that happen in your practice very often, if you say, I'm not going to treat you?
Yes, I mean, patients are also in the internet screening for some interesting things, and they might even find some things like, drinking a lot of green tea or things like this. And when they ask, one of the frequent questions they ask me is, can I do anything instead of just waiting? Are there any, paramedical things, paramedicine things I can take?
So that's really good. So rather than waiting for something to happen, here are a few things proactively that will benefit you anyway, like exercise and diet and everything. Excellent. I'm very glad I'm not a hematologist. I just actually talk about how you should talk to patients about these things. But I would like to just step back again to look at what the levels of anxiety and depression in patients actually are. There aren't very good data, in fact, in CLL. So any of you out there who are keen to do some good new projects, I think it's a really important area to research, particularly because anxiety and uncertainty are very sort of closely linked. There has been systematic reviews of the data that are out there. They're not desperately good because lots of people use different sorts of assessment measures. But what we do know is that anxiety is probably between a quarter and a third of patients that have measurable anxiety, and that's whether they're on watchful waiting or on treatment. But depression is about 25%, significantly higher in the treatment group. Now, this could, of course, be because patients actually who have to start treatment or further lines of therapy recognize that their disease is perhaps more serious. Now, I know that there's some interesting work that's been going on looking at the molecular underpinnings, that why we should really be measuring depression particularly.
Right. There's indeed some early work, and I know that many people are sitting in this audience being very interested also in molecular science. I just give you 3 examples. So we know for depression and bipolar disorders, there is a SNP for BCL2. So the SNP RS 9565 7-2, you can write this down, is associated with an exchange or turbulences in the calcium household, and this is associated with depression. So we all know that BCL2 is one target in CLL, and so it might be worthwhile also studying these effects. Second example, we know one of the classics in treatment of depression is lithium. Lithium increases the BCL2 levels. So you might conclude blocking BCL2 might do something else, decreasing BCL2 levels that we know, but also might foster depressive episodes. And there are other genes, it's the so-called BCL2 associated ethanogene, BAG, B-A-G, BAG1, BAG2, is also associated with depression. And you don't have to be a super scientist in order to think that, perturbating the BCL2 pathway with our modern drugs, we might also impact on these kind of, in this case, is a MAP kinase associated pathway, that there can be something going well or wrong, depends. But I think we have really to invest more science also in mental health issues. We could integrate this in randomized clinical trials to see whether we really decrease or increase depression disorders, and we could even associate this with molecular markers. I think this is an interesting topic. There are, in other fields of cancer research, first trials investigating this, and I would just, just fast a little bit. This should also be done in the CLL field.
Absolutely, I think that's important. And I mean, anything that sort of affects or improves anxiety and depression can only be helpful on multiple terms, particularly as, we're very triumphant about the fact that there's less need now for chemotherapy, but oral therapies, of course, do depend on patients taking the pills, and depressive patients often don't take them, They don't adhere. So if we can sort of summarize some of this, I mean, we could have probably stayed here all day talking about these things, but I think sort of the communication side really needs sort of addressing properly and thoroughly. One needs to be empathic and understanding, which I'm sure you are, but also there isn't one set pattern that is going to actually fit all patients, given their underlying and pre-existing personality predispositions. I think being honest is important, but that demands also offering reassurance and thinking about the words being used. I think we should get rid of watchful waiting for a start. You're doing active surveillance. That sounds much more positive to the patients. Also, I think reducing the patient's uncertainty can only be achieved by probably again saying, honestly, we don't want to start treatment until we feel it will genuinely benefit you, and that's why we will be measuring things. You don't have to keep on checking every few hours whether you've got a lump or a sore throat or whatever. So I wonder if there's anything you'd like to add, Clemens, about what you feel, particularly for maybe younger people who haven't got a lot of experience in dealing with this concept?
I think it's also the wording very, very important. So I also never say watch and wait. I always say watch and live. That's my expression. I always say to the patients, if you have questions after we've talked, because questions come later, just give me a call or just come back to the office to get this kind of, feedback loop and reassurance on the patient side.
I think actually there's just one little thing I'd add to that also, is that I think it's always worthwhile checking online what the charities, what other things your patients are looking at, because very often they show concordance with what you're saying, and that will increase uncertainty even more.